January 1945. Somewhere along the Western Front, inside a canvas-walled U.S. field hospital. The air is thick with antiseptic and damp winter cold. Lantern light flickers against stretched fabric walls, casting long, uneven shadows across rows of cots. Outside, artillery rumbles in the distance dull, constant like a storm that never quite passes. On one of those cots lies a young German prisoner of war, barely more than a girl. Her uniform, now stripped of insignia, is stained with mud and dried blood. One leg is heavily wrapped in field bandages, darkened where the wound beneath has begun to seep through. She watches the approaching surgeons carefully, not with defiance, but with fear shaped by months of war, propaganda, and uncertainty. Her hands grip the blanket tightly as the medical team prepares to examine the injury. The bandage has not yet been removed. And in that moment, before anyone touches it, the war feels very closed, very personal. Beyond this quiet scene, a much larger system was already in motion. By January 1945, the war in Europe had entered its final violent phase. All along the Western Front, Allied forces pressed deeper into Germany's borders. Following the breakout from Normandy in mid-1944, U.S., British, and Canadian armies had advanced across France, through Belgium, and into the industrial heartlands that sustained the German war machine. Cities that had once symbolized strength owned Cologne, Strasbourg had either fallen or were under relentless assault. Germany itself was no longer fighting for expansion. It was fighting for survival. The German military, once defined by rapid coordinated offensives, had been reduced to fragmented resistance. Entire divisions were under strength. Supplies were scarce. Fuel shortages, crippled movement. What remained of the Wehrmacht and SS units often relied on improvised defenses holding ground, not because it was strategic, but because there was nowhere left to retreat. And as the front lines shifted closer to German soil, the composition of those defending it began to change. In September 1944, the Nazi regime authorized the formation of the Volksstürme National Militia, made up of men aged 16 to 60. Many with little to no formal training. Alongside them were members of the Hitler Youth, auxiliary helpers, and in some cases, civilians drawn into roles they had never prepared for. Young girls served as communications aides, anti-aircraft assistants, and support personnel. By the final months of the war, the distinction between soldier and civilian had begun to blur. This shift carried consequences. As Allied forces advanced, they encountered increasing numbers of wounded individuals who did not fit the traditional image of combatants. Among prisoners of war were teenagers, elderly men, and young women, many injured during chaotic retreats, air raids, or last-minute defensive actions. The battlefield itself had become less defined. Artillery fire reached into towns and villages. Airstrikes targeted railways, supply routes, and urban centers. Civilians were often caught in the same destruction as soldiers. When these individuals were captured or found wounded, they were processed through the same system as any other POW registered, disarmed, and, if necessary, treated. This is where the U.S. Army Medical Department played a critical role. By 1945, American military medicine had become one of the most advanced and organized systems of the war. Lessons learned from earlier campaigns in North Africa and Italy had transformed how casualties were handled. Mobile field hospitals were positioned close behind the front lines. Evacuation chain stretching from battlefield aid stations to surgical units and then to general hospitals were designed to move the wounded quickly and efficiently. Speed meant survival. Wounded soldiers, whether American or enemy, were typically stabilized within hours. Field surgeons operated under immense pressure, often working long shifts with limited rest. Their task was not to decide who deserved care but who could be saved. Triage determined priority based on medical urgency, not nationality. This principle extended to prisoners of war. Under international law, specifically the Geneva Convention of 1929, wounded POWs were entitled to the same standard of medical treatment as the capturing force's own soldiers. In practice, U.S. medical units largely adhered to this obligation. German prisoners, once disarmed, were no longer considered combat threats. They became patients. Still, the reality on the ground was complex. Many German prisoners arrived with deep-seated fears. Years of propaganda had warned them that capture, especially by Western allies, could mean humiliation, neglect, or worse. Some expected retaliation for the destruction caused by their own country's military. Others simply did not understand what would happen next. For younger prisoners, this uncertainty was even more pronounced. They had grown up in a system that emphasized loyalty, sacrifice, and distrust of the enemy. But now, lying wounded in unfamiliar surroundings, those beliefs collided with a different reality, one shaped not by ideology, but by procedure, discipline, and medical necessity. Inside the field hospitals, the war changed form. It was no longer about territory or strategy. It became a matter of wounds, infection, and survival. Surgeons worked quickly, often without knowing the full story of the patient before them. Names, ranks, and backgrounds were secondary to the condition of the injury. And increasingly, those injuries told a different kind of story, one of a collapsing nation sending its youngest and most vulnerable into the path of advancing armies. The girl lying on that cot was not an isolated case. She was part of a larger pattern emerging in the final months of the war, a pattern that would test not only the endurance of armies, but the principles they claimed to uphold. And to understand how those principles were applied in practice, it becomes necessary to look closer at the rules and the reality of treating enemy wounded under care. By the time Allied forces crossed into German territory, the treatment of prisoners of war was no longer just a matter of logistics. It was a matter of law, discipline, and reputation. The framework guiding that treatment had been established years earlier. Under the Geneva Convention of 1929, it outlined clear obligations. Captured enemy soldiers were to be protected from violence, provided with food and shelter, and critically given medical care equal to that of the captor's own troops. Wounded prisoners were not to be neglected or discriminated against. In theory, once a combatant was disarmed and detained, the battlefield no longer applied to them. In practice, adherence to these rules varied across different fronts and armies. But within us forces in Europe, there was a consistent effort, both official and institutional, to follow these standards. American field hospitals operated under strict protocols. Medical personnel were trained to treat injuries based on urgency, not identity. A wounded German prisoner could be placed on the same operating table, under the same surgical light, as an American infantryman who had been evacuated minutes earlier. The decision was guided by triage categories: immediate, delayed, minimal, or expectant. This system left little room for personal judgment. Doctors and nurses often did not ask how a patient had been injured, or what role they had played in the war. Their focus was clinical: bleeding, infection, fractures, shock. The uniform, once removed or cut away, no longer defined the individual in front of them. Still, the emotional distance was not always easy to maintain. By 1945, many American medical units had witnessed the full scale of the war's brutality. They had treated soldiers wounded in Normandy's hedgerows, in the flooded plains of the Netherlands, and during the freezing conditions of the Ardennes offensive. Some had also begun to encounter evidence of Nazi concentration camps as Allied forces advanced eastward. These experiences shaped perception. Yet even within that context, medical discipline remained a defining standard. The role of a surgeon was not to judge but to preserve life where possible. This principle extended even to those who, only hours before, had been part of the opposing force. For German prisoners, however, expectations were often very different. Years of state-controlled messaging had portrayed Allied troops, particularly Americans, as unpredictable or hostile. Civilians and auxiliary personnel, especially younger individuals, had limited exposure to anything beyond that narrative. Capture was often imagined as the end of control, a moment where fear replaced certainty. This psychological tension followed them into captivity. When wounded prisoners arrived at U.S. field hospitals, they entered an environment that contrasted sharply with what they had been led to expect. The process was structured, almost routine. Weapons were confiscated. Names and basic details were recorded when possible. Then came examination, quick, efficient, and focused. For those with serious injuries, there was little delay. Clothing was cut away, Bandages applied in the field were removed. Wounds were cleaned, assessed, and, if necessary, prepared for surgery. Infection was a constant concern, particularly in winter conditions where mud, debris, and delayed evacuation increased the risk of complications. For patients, especially those already in pain or shock, this process could feel abrupt. There was little time for explanation. Language barriers added another layer of uncertainty. Not all medical staff spoke German, and not all prisoners understood English. Communication was often reduced to gestures, tone, and the visible actions of the medical team. In these moments, perception mattered as much as procedure. A surgeon, leaning over a patient, removing a bandage, could be seen as either a source of help or a source of fear. For someone raised to distrust the enemy, the distinction was not immediately clear. And yet outcomes began to speak for themselves. Many German prisoners who survived their injuries did so because of the care they received after capture. Records from U.S. medical units indicate that treatment standards were generally maintained even under pressure. While conditions in frontline hospitals were far from comfortable, they were often safer than the environments from which these wounded had come. Over time, this created a quiet contradiction. The expectations carried into captivity did not always match the reality experienced within it. For some, that realization came slowly over days or weeks of recovery. For others, it began in a single moment. A moment when the bandage was about to be removed, when the outcome of that action was unknown, and when everything they believed about the enemy was about to be tested against what actually happened next. By the final months of the war, the human landscape of Germany had changed as dramatically as its military one. Many of those now caught in the path of advancing Allied forces had not been part of the war at its beginning. They were too young then. Their understanding of conflict had been shaped not by experience, but by instruction schools, youth organizations, controlled media. Loyalty was emphasized. Sacrifice was expected. The enemy was described in simple, absolute terms, but reality, when it arrived, did not follow those definitions. For younger individuals, especially those drawn into auxiliary roles or emergency defense units, the transition from belief to experience was abrupt. One day they were part of a system that felt structured, even purposeful. The next, they were wounded, disoriented, and in the custody of the very forces they had been taught to fear. Inside the field hospital, this shift became deeply personal. The girl on the cot is part of this moment. Her injury is not only physical, it represents the end of a controlled narrative. The uniform she wore no longer carries authority. The environment around her is unfamiliar. Voices are in another language. Actions are quick, efficient, and not always explained. Fear in this context is not abstract. It is immediate and focused. It centers on what will happen next, on whether pain will increase, on whether the people standing nearby intend to help or harm. These are not questions formed through logic, but through uncertainty shaped by months, sometimes years, of conditioning. And yet, within that fear, there is also stillness, a waiting period. A moment before action, the seconds before a bandage is removed, before a decision is made. It is in that space, quiet, tense, and unresolved, that the human dimension of war becomes most visible. Because in that moment, identity fades. What remains is simply a young person, injured, unsure, and dependent on others for survival. Medical angle battlefield surgery under pressure, the field hospital was not designed for comfort. It was designed for speed. Positioned close enough to the front to receive casualties quickly, yet far enough to avoid direct fire, these units formed a critical link in the chain of survival. Every minute mattered. Blood loss, infection, and shock did not wait for ideal conditions. By 1945, U.S. medical teams had refined their approach through years of experience. When a patient arrived, the process began immediately. Triage officers assessed severity. Those in critical condition were prioritized for surgery. Others were stabilized and placed in holding areas. There was no distinction in urgency between friend and foenly. The condition of the wound determined the order of care. For surgeons, the environment demanded precision under limitation. Lighting was often artificial and uneven. Equipment, though advanced for its time, was finite. Sterilization procedures were maintained as strictly as possible, but the realities of war meant that contamination risks were always present. Winter conditions added further complications, cold temperatures slowed circulation, while dampness increased the likelihood of infection. Leg injuries, such as the one carried by the girl on the cot, were among the most complex. They could involve fractures, embedded shrapnel, soft tissue damage, and compromised blood flow. A bandage applied in the field was only a temporary measure. Beneath it, the true condition of the injury could be far worse than it appeared. Removing that bandage was not a simple act. It was a point of assessment, a moment where the surgeon determined whether the limb could be saved or whether more drastic measures were required. Delay could mean infection spreading. Acting too late could mean losing the patient entirely. These decisions were made quickly, but not carelessly. Medical teams followed established protocols, balancing urgency with caution. Anesthesia, when available, was administered. Assistants prepared instruments. Communication between staff was brief, focused, and often conducted in a mix of technical language and practiced routine. For the patient, however, this process could feel overwhelming. There was little time for reassurance. The removal of a bandage, the exposure of a wound, the presence of unfamiliar faces all contributed to a sense of vulnerability. Even when the intention was to help, the experience itself could be difficult to interpret. And yet, this system, imperfect, pressured, and relentless, saved countless lives. It transformed chaos into procedure, injury into action, and in doing so, it created moments where survival depended not on allegiance, but on the skill and discipline of those working under canvas roofs, far from permanence. Cultural angle. Propaganda meets reality for years. The war had been fought not only with weapons, but with words. In Germany, information was tightly controlled. News, images, and narratives were shaped to maintain morale and reinforce loyalty. The enemy was portrayed as dangerous, often dehumanized, and fundamentally different. These portrayals were not always specific, but they were consistent. They created expectation. For many Germans, especially the young captured by Allied forces, was imagined as a transition into uncertainty, not outright danger. Stories circulated, sometimes exaggerated, sometimes entirely fabricated. Without alternative sources of information, these ideas went largely unchallenged. But the field hospital introduced a contradiction. Here, the enemy did not behave as expected. Medical staff followed procedure. They treated wounds. They worked to preserve life. Their actions were not shaped by ideology, but by training and obligation. For a prisoner entering this environment, the difference could be difficult to process. The visual cues were their uniforms, insignia, language, but the behavior did not match the narrative. This did not immediately erase fear. Beliefs formed over time are not undone in a single moment, but the experience created tension between expectation and reality. Each action, careful, methodical, and directed toward healing, added to that tension. In some cases, it led to a gradual shift in perception. Not a complete transformation, but a recognition that the situation was more complex than previously understood. That the enemy, in certain contexts, could act according to a different set of rules. The removal of a bandage then becomes more than a medical act. It becomes a test. A point where belief meets experience, where fear anticipates one out-command, reality may deliver another. And in that narrow space, something begins to change, even if only slightly. These perspectives, human, medical, and cultural, begin to frame the moment not as an isolated incident, but as part of a larger convergence shaped by war, training, and perception. But beyond these layers, there are still deeper forces at work: tactical decisions, command priorities, and the broader collapse unfolding across Germany. By early 1945, the Western Front no longer moved in measured advances. It surged. After the failure of the German counteroffensive in the Ardennes in December 1944, Allied forces regained momentum. What followed was a rapid push toward the Rhine River, the last major natural barrier before the heart of Germany. Towns changed hands quickly. Defensive lines were formed and abandoned within days, sometimes hours. This pace created a specific kind of chaos. Units were often forced to withdraw under pressure, leaving behind not only equipment but also wounded personnel who could not be evacuated in time. Medical infrastructure on the German side had been severely weakened by sustained bombing campaigns. Rail networks were disrupted. Fuel shortages made transport unreliable. Field hospitals, where they still existed, were frequently overwhelmed or forced to relocate. As a result, increasing numbers of wounded fell into Allied hands. Some were discovered in abandoned positions. Others were brought forward by advancing troops. Many had received only basic first aid bandages applied quickly under fire, without the means for proper cleaning or stabilization. Hours, sometimes days, had passed before they reached a facility capable of real treatment. This delay changed the nature of their injuries. Wounds that might have been manageable earlier became more severe. Infections spread, tissue damage worsened. Circulatory problems increased the risk of permanent loss of function. By the time these individuals arrived at U.S. medical units, the situation was often critical. And among them were not only trained soldiers. The collapse of organized defense meant that auxiliary personnel, including young assistants and militia members, were exposed directly to frontline conditions. When they were wounded, they entered the same chain of capture and care as any other combatant. From a tactical perspective, this created an unusual burden. U.S. medical units had to balance the treatment of their own casualties with those of the enemy. Resources, time, personnel, equipment were limited. Yet the principles guiding their operations required that treatment be based on urgency, not allegiance. This was not always easy, but it was consistent. The field hospital became a point where the consequences of strategic collapse were concentrated. Every patient arriving carried the result of a larger decision made elsewhere on a command map. In a headquarters far removed from the immediate reality of injury. And as the number of wounded increased, so did the frequency of moments like the one unfolding on that cot, moments where the outcome depended not on strategy, but on what a surgeon would find beneath a bandage. Leadership angle, discipline, doctrine, medical command. Behind every field hospital stood a structure of command that extended far beyond the canvas walls. The U.S. Army Medical Department operated under a doctrine shaped by both necessity and principle. Its objective was clear: preserve as many lives as possible, maintain the fighting strength of the Army, and uphold international standards of care. This doctrine was not abstract. It was enforced through training, supervision, and accountability. Medical officers were expected to lead by example. They organized evacuation routes, ensured supply chains for medical equipment, and maintained standards of hygiene and procedure under conditions that often made such standards difficult to achieve. They also carried the responsibility of ensuring that prisoners of war were treated in accordance with established conventions. This was not left to individual interpretation. Orders were explicit. Wounded enemy personnel were to receive care equivalent to that of soldiers. Within the limits of available resources, violations of this principle could result in disciplinary action. The consistency of this approach contributed to a system that, while not without flaws, remained structured even under pressure. For surgeons and medical staff, leadership translated into routine. They did not decide policy in the moment. They applied it. Each case was approached through the same sequence: assessment, stabilization, intervention. Personal feelings, whether shaped by fatigue, loss, or the broader context of the war, were expected to remain separate from clinical judgment. This separation required discipline. By 1945, many medical personnel had treated hundreds, sometimes thousands, of casualties. They had seen the effects of artillery, mines, and small arms fire. They had operated under bombardment, relocated under threat, and worked through exhaustion. Yet the expectation remained unchanged. Every patient was to be treated according to need. This environment shaped the moment at the bedside. The decision to remove a bandage to proceed with surgery, or to alter a course of treatment, was not influenced by who the patient had been before capture. It was guided by what was medically necessary now. And in that sense, leadership extended into every action. It was present in the way instruments were prepared, in the coordination between staff, and in the quiet assurance that procedure would be followed even when the situation was uncertain. Enemy angled Germany's final mobilization on the other side of the line. Germany's position had become untenable. The strategic situation in early 1945 was defined by pressure from multiple directions. Soviet forces advanced from the east, pushing toward Berlin. In the west, Allied armies approached the Rhine. The Luftwaffe had been largely neutralized. Industrial output had declined under sustained bombing. Communication lines were disrupted. In response, the German leadership turned increasingly to total mobilization. The concept was simple. Every available individual would contribute to the defense. This included not only trained soldiers, but also those with minimal preparation. The Volkssturm, established in late 1944, embodied this approach. Units were formed quickly, often equipped with outdated weapons and deployed with limited coordination. Alongside them were auxiliary roles filled by younger individuals. These roles were not always intended for direct combat, but the conditions of the war made such distinctions difficult to maintain. As front lines shifted and defensive positions collapsed, support personnel found themselves exposed to the same dangers as frontline troops. This created a generation of participants who were unprepared for the realities they faced. Their training, if it existed, was brief. Their understanding of the enemy was shaped by ideology. Their experience of combat was often sudden and overwhelming. When they were wounded, they entered a system that contrasted sharply with the one they had known. The field hospital then became a point of transition, not only from injury to treatment, but from one understanding of the war to another. The expectations carried into that space were often rooted in fear. The reality encountered there, shaped by procedure and discipline, could challenge those expectations. But that challenge did not erase uncertainty. For the girl on the cot, the broader collapse of Germany is present, even if unseen. It is reflected in how she arrived there and the circumstances that placed her in uniform. In the injury she sustained, and in the fact that her survival now depends on those she had been taught to distrust. And as the surgeon reaches for the bandage, all of these layers, tactical, structural, and human, converge into a single, decisive moment. Inside the field hospital, the rhythm of movement continues, but around one cot, it slows. The surgical team is gathered. Instruments are laid out in ordered rows, their metallic surfaces catching the dim lantern light. A basin of sterilized tools rests nearby. Gauze, clamps, scissors, each placed with purpose. The air carries a sharper scent now, antiseptic layered over the lingering cold of canvas and winter air. The girl remains still. Her injured leg is elevated slightly, the bandage wrapped thickly from below the knee downward. It is no longer clean. What had once been white is now darkened in patches, evidence of bleeding that has seeped through layers applied hours earlier, possibly under far less controlled conditions. A medic adjusts the lantern, bringing more light to the wound. One of the surgeons steps closer. His movements are deliberate, practiced. There is no hesitation, but neither is there urgency that would suggest panic. Around him, the rest of the team prepares in silence. An assistant readies additional gauze. Another checks the available anesthetic. Time is limited, but not rushed. Before anything else, the bandage must come off. The outer layers are removed first. Carefully, the surgeon begins to unwind the cloth, layer by layer. Each turn reveals more of what lies beneath, but only partially. The bandage has adhered in places, dried blood binding fabric to skin. Where resistance is felt, the motion slows. A pair of scissors is used to cut through sections that cannot be safely unwound. The process is methodical. There is no sudden movement, no force. Each action is controlled, designed to expose the injury without causing further damage. Still, the act itself is not without discomfort. Even slight movement can disturb tissue already inflamed. As the layers thin, the outline of the injury begins to take shape. Swelling is visible first, then discoloration. The skin around the wound shows signs of trauma, darkened areas where circulation may be compromised. The final layer, closest to the injury, is more difficult to remove. It has absorbed the most blood, the most debris. The surgeon pauses briefly, not to delay but to assess. An assistant brings forward a small amount of saline solution. Fabric is moistened to ease separation from the underlying tissue. This reduces the risk of tearing newly formed clots or causing additional bleeding. The technique is standard but essential. Slowly, the last layer begins to lift. What is revealed is no longer obscured by cloth. The wound is exposed. Injuries of this kind, common in the final stages of the war, often result from shrapnel or explosive fragments. Unlike clean fractures, they are irregular. Edges are uneven. Foreign material, metal, dirt, fabric, may be embedded deep within the tissue. The initial bandage applied in the field would have been intended only to control bleeding, not to fully clean or repair. Now, under the lantern light, the full condition becomes clear. The surrounding tissue shows signs of contamination. There is swelling that suggests internal damage beyond what is immediately visible. The possibility of infection is no longer theoretical, it is likely already present. For the surgical team, this is the critical moment. Diagnosis shifts into decision. The surgeon leans closer, examining the depth and spread of the injury. He checks for signs of compromised blood flow. The color of the skin, the response of the tissue, the presence of debris, all of these factors are evaluated quickly but thoroughly. An assistant notes observations. Another prepares instruments that may be required depending on the outcome. There are several possible paths forward. If the damage is contained, the wound may be clean debrided to remove foreign material and dead tissue, then stabilize for recovery. If fractures are present, they may require alignment and immobilization. But if circulation has been severely compromised, or if infection has spread too far, the options narrow. Delay in such cases can be fatal. The decision must be made here. The environment remains quiet, but the tension is precise, not emotional, but clinical. Every movement now carries weight. The difference between preservation and loss is measured not in minutes, but in judgment. For the girl on the cot, this moment is suspended. She cannot see the full extent of the injury. She can only sense the change in activity, the shift from removal to examination, the presence of multiple hands, the stillness that follows. What happens next will determine not only the condition of her leg but the course of her survival, and as the surgeon straightens slightly, preparing to act on what he has seen, the room moves one step closer to a decision that cannot be reversed. The examination ends, but the decision does not linger. In a field hospital, hesitation carries its own risks. The surgeon has seen enough. The wound is not clean. It has been too long since the injury occurred. Foreign material remains embedded deep within the tissue. The surrounding area shows clear signs of compromised circulation. The swelling is not only external, it suggests pressure building beneath the surface. Infection is no longer a possibility. It is already present. The question is no longer what happened. The question is, what can still be saved? The surgeon gives a brief instruction. Assistants move immediately. The tone remains controlled. No raised voices. No visible urgency. But the pace increases. Instruments are repositioned. Additional gauze is brought forward. Anesthetic is prepared and administered with care, adjusted to the patient's condition and the limitations of the setting. There is no ceremony in the transition from examination to procedure. Only sequence. The first step is stabilization. The wound is irrigated, flushed with sterile solution to remove debris and reduce bacterial load. This is done thoroughly, not quickly. Every visible fragment must be cleared. Dirt, fabric, metal all are removed where accessible. Next comes debridement. Damaged tissue cannot remain. It becomes a source of infection, a barrier to healing. Using precise instruments, the surgeon removes sections that are no longer viable. The process is exacting. Each cut is measured. The goal is not speed, but preservation, removing only what cannot be saved. The extent of this step depends on what was revealed during examination. In some cases, this is enough. But here, the injury has progressed further. Circulation below a certain point is no longer reliable. The color of the tissue, the lack of response, the structural damage, these indicators point in a single direction. Attempts to preserve the limb would risk allowing infection to spread beyond control. In the confined conditions of a field hospital, with limited antibiotics and no guarantee of prolonged care, that risk is significant. The surgeon makes the determination, not lightly, not emotionally, but with clarity shaped by experience. The priority is survival. Assistants adjust their positions. Instruments are exchanged. The procedure shifts from repair to removal of what cannot be sustained. Throughout, the environment remains focused. Every member of the team understands their role. Movements are coordinated, practiced, and deliberate. Time passes differently in such moments, measured not by clocks, but by stages of completion. Bleeding is controlled. Tissue is managed. The procedure advances step by step, guided by both training and necessity. There is no excess motion, no unnecessary pause, only the continuous application of method. For the patient, awareness fades under anesthesia. The fear that had defined the earlier moments gives way to stillness. The outcome, whatever it will be, is now in the hands of those working above her. And for the surgical team, the task remains unchanged until the final step is complete. When it is over, the pace slows again. Instruments are set aside. Dressings are applied, clean, secure, and designed to protect what has been preserved. The wound, now treated according to the limits of what was possible, is no longer a source of immediate threat. But the result is definitive. What could not be saved has been removed. What remains is stable. The surgeon steps back slightly, observing the work. There is no outward expression of relief or regret, in confirmation that the objective has been met. The patient has survived the procedure. The immediate danger has been contained. Around the cot, the team begins to reset. Used instruments are cleared. Surfaces are prepared for the next case. The rhythm of the hospital resumes as it must. There are always more patients, more injuries, more decisions waiting. But for a brief moment, the focus remains here. A transition has occurred. What began as uncertainty, fear shaped by expectation, has moved through examination, through action, into outcome. The reality of the situation is no longer unknown. It has been defined not by assumption, but by what was necessary. And in that definition, something else begins to take shape. Not immediately, not fully understood, but present. A realization that the hands which removed the bandage did not act with harm in mind, but with purpose grounded in preservation. The war, outside the canvas walls, continues unchanged. But inside, for one patient, the meaning of that war has shifted quietly and without announcement. When the procedure ends, the urgency does not disappear, changes form. The girl is moved from the surgical area to a recovery cot within the same field hospital system. The environment is quieter here, though never silent. The distant sounds of movement, low voices, and occasional equipment remain constant. Around her are others, some recently treated, others awaiting their turn. Each is part of the same cycle: arrival, intervention, stabilization. Her condition is now monitored closely. Dressings are checked for bleeding. Pulse and respiration are observed at regular intervals. In the absence of modern monitoring equipment, these assessments rely on direct observation, trained eyes, practiced routines. Any sign of complication must be identified early. Infection remains the primary concern. Even after surgery, the risk does not end. Antibiotics such as penicillin are available by this stage of the war, but supply is not unlimited. Their use is prioritized, carefully administered to cases where the benefit is most critical. Wounds are cleaned repeatedly. Dressings are changed under as sterile conditions as the environment allows. Pain management is provided, though within limits. Medication is used to reduce suffering, but resources must be balanced across many patients. Recovery in this context is not comfort, is stability. The goal is to ensure that the patient survives the critical period following surgery, where complications are most likely to occur. For prisoners of war, this phase is often their first sustained exposure to the routines of Allied care. Guards may be present, but their role is passive. Security is maintained, yet the atmosphere is not one of confinement in the traditional sense. Movement is limited due to medical necessity, not enforcement. The distinction, while subtle, becomes noticeable over time. Food is provided regularly. Rations are basic, consistent with military standards, but sufficient. Water is available. Blankets are issued. These details, routine to those managing the facility, carry different meaning for those experiencing them after capture. Records are kept. Each patient is documented condition, treatment, progress. These records serve both medical and administrative purposes. They ensure continuity of care and provide accountability. In larger facilities, this system allows patients to be transferred to more permanent hospitals once their condition stabilizes. Survival rates in U.S. medical units during this period reflect the effectiveness of these processes. While exact outcomes vary depending on the nature of the injury and the timing of treatment, advances in surgical technique, antibiotics, and evacuation systems significantly improved the chances of recovery compared to earlier stages of the war. Many who would not have survived in previous conflicts were now able to recover, at least to a stable condition. For German prisoners, this often meant an unexpected outcome. They had been removed from the battlefield not only as combatants, but as patients. Their continued survival depended on a system operated by those they had been taught to oppose. The contradiction was not always addressed directly, but it was experienced day by day. As the girl regains awareness, the immediate intensity of the earlier moments has passed. The bandage is new. The pain is different, controlled, but present. The environment is no longer defined by uncertainty, but by routine. She is no longer waiting for a decision. That decision has already been made. What remains is the process of recovery. Around her, the hospital continues its work. New patients arrive. Others are moved out. The flow does not stop. Each case follows its own path shaped by injury and response. Yet within this constant movement, a pattern holds, one defined by structure, consistency, and the application of care under constraint. And beyond the boundaries of the hospital, the war continues to move toward its conclusion, bringing with it consequences that extend far beyond any single patient or procedure. Beyond the canvas walls of the field hospital, events were accelerating toward an end that only months earlier had seemed distant. By early 1945, Allied forces were preparing for the final crossings into the core of Germany. In March, U.S. troops would secure a critical bridge over the Rhine at Remagen, opening a direct path into the interior. From there, the advance would continue rapidly west to east, town by town, city by city. Resistance remained, but it was increasingly fragmented. Germany's capacity to sustain the war was collapsing. Industrial production had been severely reduced. Transportation networks were disrupted. Command structures struggled to maintain coordination across shrinking territory. In April, Soviet forces would enter Berlin. Within weeks, the German leadership would disintegrate, culminating in the unconditional surrender signed in May 1945. For those already in Allied custody, including the wounded in field hospitals, these developments changed their status. They were no longer part of an active military effort. They became part of a post-war system, one focused on containment, recovery, and eventual repatriation. Prisoner of war camps expanded to accommodate the growing numbers. Medical facilities transitioned from immediate wartime treatment to longer-term care and rehabilitation. For many German prisoners, this period introduced a gradual shift in perception. Experiences varied. Documented accounts from US-run facilities often described consistent access to food, medical care, and basic living conditions. Inspections by international organizations, including the International Committee of the Red Cross, monitored compliance with established conventions. While conditions were not without hardship, overcrowding, and resource, limitations remained real concerns. The overall structure emphasized order and maintenance rather than punishment. This stood in contrast to expectations formed during the war. For individuals who had been exposed primarily to controlled narratives, The experience of captivity under these conditions could be disorienting. It did not erase the broader reality of the conflict, nor the losses that had occurred. But it introduced a different understanding of the opposing side, one based on direct experience rather than distant description. The girl who had entered the field hospital as a wounded prisoner becomes part of this broader transition. Her recovery, whether complete or partial, unfolds within a system that continues beyond the battlefield. If her condition stabilizes, she may be transferred to a more permanent facility. Their rehabilitation, physical and, to some extent, psychological, becomes the focus. The immediate urgency of survival gives way to longer-term adjustment. For many in similar situations, the end of the war did not bring immediate clarity. Germany itself was undergoing transformation. Cities lay in ruins. Civilian populations faced shortages and displacement. The structures that had defined daily life had been dismantled. Returning home, for those who could, meant entering a country that no longer resembled the one they had left. Yet within this uncertainty, certain records remained consistent. Medical logs, inspection reports, and post-war analyses indicate that the treatment of German prisoners by U.S. forces generally adhered to the standards set out in international agreements. Survival rates for wounded prisoners improved significantly compared to earlier conflicts. Access to care, even under difficult conditions, was maintained as a priority. These outcomes did not change the course of the war, but they shaped its human dimension. They influenced how individuals understood their experience, how they interpreted the actions of others, and how they carried those memories into the post-war world. In some cases, they contributed to a gradual rebuilding of perception, an acknowledgement that even within a conflict defined by destruction, there were systems that operated according to different principles. Inside the hospital, the routines continue. Patients recover, or they do not. Staff move from one case to the next. The work remains constant, even as the larger war moves toward its conclusion. And in that steady, methodical environment, the significance of individual moments like the removal of a bandage, or the decision that followed, begins to settle into something more lasting, not dramatic, not widely recorded, but real. War is often remembered through movement, armies advancing, borders shifting, cities falling, but its meaning is just as often found in stillness. Inside a field hospital, far from the noise of direct combat, the conflict narrows into something quieter. A single patient, a single decision, a moment where identity, uniform, nationality, allegiance becomes secondary to something more immediate: survival. The girl on the cot entered that space carrying more than an injury. She carried expectation, fear shaped by distance, by instruction, by a version of the enemy that had never been tested. And for a brief moment, as the bandage was about to be removed, those expectations held their weight. What followed did not erase the war. It did not undo the destruction outside or the losses already endured. But it introduced a different kind of encounter, one governed not by ideology but by procedure. Not by hostility, but by responsibility. In that setting, the outcome was determined by skill, by training, and by a commitment that extended beyond sides. These moments rarely appear in headlines or official summaries. They are not marked by victory or defeat. Yet they persist in records, in memory, in the quiet continuity of medical logs and post-war accounts. They remind us that even within systems built for conflict, there are spaces where the objective shifts from defeating an opponent to preserving a life. And sometimes history is shaped not only by what is destroyed, but by what is deliberately, carefully, and quietly saved.